7 components go into making up levels of E&M services: history, examination, medical decision-making, counseling, coordination of care, nature of present problem, and the time. History, examination, and medical decision-making are considered the key components. Counseling, coordination of care, and nature of presenting problem are considered contributory components. Time is unique in that it can or cannot contribute to code selection, depending on other factors of the case. To fully understand how these 7 components should influence your choice of a level of E&M service code, we will look at each one individually. The first 3 components are key because they are universally recognized as the basis for choosing a level of service for a patient encounter. The first is history. 4 types of history appear in the Evaluation and Management Codes. They are problem-focused, expanded problem-focused, detailed, and comprehensive. And coders must determine the type of history documented in the patient's record in order to select the appropriate level of history. We must first have an understanding of the elements that determine the various history types. Each type of history is based on the following elements: the chief complaint, history of present illness, review of systems, and past family and social history. The chief complaint for each patient history is defined as the reason for the patient encounter. Should it be recorded in the patient's record and in the words of the patient, and why the patient is seeking care. The history of present illness is also recorded as part of the history and is a chronological description of the patient's present illness. The HPI is based on elements that describe the location of the problem, how long the problem has been going on, the severity, the quality, timing, context, modifying factors, and also the associated signs and symptoms relating to the problem. Please refer to Table 3.3 in your work text for a listing of the elements of the history of the present illness. The history of the present illness can be brief or extended. A brief HPI consists of 1 to 3 elements of the HPI, whereas an extended HPI consists of at least 4 elements of the HPI, or the status of at least 3 chronic or inactive conditions. The review of systems is an inventory of body systems that is obtained from the patient to identify signs and/or symptoms that the patient may be experiencing or may have experienced. 14 systems listed in Table 3.3 in your work text are recognized in the guidelines. There are 3 types of review of systems, or ROS. Problem pertinent, where the patient's response is to 1 system. Extended ROS, the patient is response to 2 or 9 systems. And the complete ROS, the patient's response is to at least 10 systems. Remember, the review of systems is obtained by querying the patient and is most commonly completed by a series of questions from the provider to the patient. The past family and/or social history, or PFSH, is the last portion of the HPI and consists of this PFSH. The past history includes information regarding major illnesses, surgeries, injuries, and hospitalizations, as well as current medication and allergies. Past history refers to any past medical information that may affect the medical decision-making process. Family history includes information regarding immediate family members who suffer from a chronic or acute illness that would impact care of the patient during either the current encounter or future encounters. Typically, a complete family history is obtained during the annual physical examination or an initial visit to initiate care and is updated as needed. Social history is the portion of the HPI which discusses the patient's marital status, use of tobacco, alcohol, and drugs, the patient's occupation, sexual history, and other social factors that would affect care of the patient or that the provider feels may be relevant to a comprehensive patient care. A past family and social history can be pertinent or complete. A pertinent PFSH is a review of the history area that is related to the problem identified in the HPI. To justify a pertinent PFSH, there must be one specific item from any of the 3 history areas documented. A complete PFSH is the review of 2 or all 3 of the past family and/or social history areas. The definition of a complete PFSH is dependent on the category of E&M service. SOAP notes. Many providers record encounters by using a SOAP note. The HPI is sometimes referred to as the S or the subjective portion of a SOAP note. A SOAP note contains a subjective portion, the history, an objective portion, the exam, an assessment portion, the diagnoses, and a plan, the plan for the patient's care. As discussed in the chapter, each type of history is based on the chief complaint, history of presenting illness, review of systems, and past family and social history. As mentioned earlier, the different levels of history are referred to in CPT as the problem focus history, expanded problem focus history, detailed history, and comprehensive history. All histories must include a chief complaint. The problem focus history is a brief history of the presenting illness, or HPI, which is related to the problem that has brought the patient into the office. In the documentation for the encounter, 1 to 3 elements of the history of the presenting illness are needed. An expanded problem focus history includes documentation of 1 to 3 elements of the HPI as well as a review of the system directly related to the chief complaint. No past family and/or social history is required. A detailed history includes documentation of 4 or more elements of the HPI, a review of 2 or 9 systems, and an element from the past family and/or social history which may be related to the patient's problem. The comprehensive history contains documentation of 4 or more elements of the HPI, a complete review of systems, and a complete past family and social history. The next key component in choosing an evaluation and management level of service is the examination. The examination is also recognized as the O, or objective, portion of the provider's note. This is the portion of the visit in which the provider conducts an examination of the patient. The examination portion of the evaluation and management services is based on 4 types of examination. The first type of examination is a problem-focused examination and addresses only the problem that brought the patient into the office. An expanded problem-focused examination addresses the affected area along with other body systems or areas that might be affected. A detailed examination involves not only the affected area but also related systems or organs. And the final and most extensive examination is known as the comprehensive examination, which is the highest level of examination and consists of a multi-system or a complete examination of a single organ system. Any type of exam can be performed by any physician regardless of the specialty. However, certain specialties are not paid for multi-system exams as they fall out of their particular scope of practice. The type of examination is selected by the examining physician and is based on the nature of the presenting problem, the patient's history, and the physician's clinical judgment. The level or type of the examination depends on the elements of examination, which in lay terms is the system or body area that was examined by the provider. To fully understand the elements of examination, a coder must understand the specific elements required for each exam type. This is explained in the documentation guidelines found in Appendix 5. For a multi-system exam and all the single organ examinations, there are 4 types of examinations. Table 3.5 in your work text lists the type of exam and the number of elements that must be performed and documented by the provider to justify the examination level of multi-system exams. Table 3.6 in your work text outlines the elements of an exam or bullets that have to be met to justify a given level of exam in a multi-system exam. The documentation must reflect what your provider actually did so that you can build the most accurate level of service determination possible for the visit. The final key component of selecting an evaluation and management code is the element of medical decision-making. Medical decision-making is the process of a provider completing to determine a diagnosis and then decide on a plan of care for the patient. The provider must consider several factors during the medical decision-making process: the number of diagnoses or management options, the amount and/or complexity of the data reviewed, along with the risk of complications and/or morbidity or mortality, all play a role in selection of the type of medical decision-making that is reflected in the CPT code. The documentation of the assessment, the A in the SOAP note, and the supporting thought process which leads to the plan, the P in the SOAP note, must be recorded. As stated in Appendix 5, the Documentation Guidelines for Evaluation and Management Services outlines 4 levels of medical decision-making that are referred to in CPT: straightforward, low complexity, moderate complexity, and high complexity. The complexity of these factors increases the level of medical decision-making increases as well. The Documentation Guidelines for Evaluation and Management Service offer the following table of Table 3-7 to guide the coder in selecting the correct type of medical decision-making. Please review this in your work text. Remember, to select the proper type of decision-making, 2 of the 3 elements in the table must be either met or exceeded to qualify for a given type of decision-making. The type of medical decision-making is based on 3 factors: the number of diagnoses, the amount of and complexity of the data reviewed, and the risk of complications or morbidity or mortality. The remaining elements that factor into choosing a level of service are counseling, coordination of care, and nature of present problem. These components, known as contributory factors, can contribute to the work that goes into an encounter and should be considered when determining a level of service to code. They are closely related and in many instances overlap. Coordination of care is not formally defined in CPT. However, it represents services that are completed to organize or direct the patient's care. Nature of presenting problem is defined in CPT as one of 5 types: minimal, self-limited or minor, low severity, moderate severity, high severity. The complete definition for each of these types of nature of the presenting problem is found in the Evaluation and Management Services Guidelines in CPT. The 7th factor that is indicated in some E&M codes is time. It should be noted that the time included in the codes represents an average for a specific code. CPT offers 2 definitions for time: face-to-face time, which is defined as the time the physician spends face-to-face with the patient and/or family. Although the definition of CPT specifies that the time includes time with the family, most payers, including Medicare, do not recognize the time spent with the family. They include only the time spent with the patient. And then there's unit and floor time, which is used for hospital observation services, inpatient hospital care, initial follow-up hospital consultations, and nursing facilities. The time, according to CPT, this time includes the time that the physician is present on the patient's unit and at the bedside rendering services. Also included is the time in which the physician documents patient information and reviews the patient chart, examines the patient record, and communicates with other professionals and the patient's family. This is another area where various payers interpret the definition differently. CPT has a specific code range for hospital coding. CPT is divided into initial hospital care codes for admissions and subsequent hospital care codes for additional visits after the admission. These categories include both new and established patients. Initial hospital care codes depend on the level of service that is rendered. These codes are usually used by the admitting physician to report the first hospital inpatient encounter. This range of codes is not used by other physicians. It is only for the admitting physician and is reported only once per hospital admission. All services that were performed by the physician are considered part of the initial hospital care when they are performed on the same date of the admission. Subsequent hospital visits are billed with codes from the 99231 through 99233 code range. Hospital discharge codes 99238 through 99239 indicate that a patient has been discharged from the hospital. The coder would use code 99238 or 99239, and these codes are time-based and include all services provided to a patient on the date of discharge. Code 99238, Hospital Discharge Day Management, 30 minutes or less, is the standard discharge and is used to indicate that the work involved in discharging a patient took approximately 30 minutes or less. Observation services are when a patient is admitted for observation or observation status, and the patient has not been admitted to the hospital as an inpatient, but needs to be admitted under observation status for assessment. Observation indicates the patient is in the hospital for a short time, usually less than 24 hours, but sometimes as long as 48 hours, to determine the course of care. The patient may ultimately be released to go home or may be admitted to the hospital as an inpatient in an effort to offer more extensive care. Codes 99218 through 99220 are used for new or established patients who are admitted under observation status. CPT code 99217, observation care discharged, is used when a patient is discharged from an observation on a date that may be different from the date of admission to observation. Codes 99234 through 99236, observation or inpatient care services, including admission and discharge, are used when a patient is admitted and discharged on the same date of service. The important point to remember is that codes 99234 and 99236 are used only in the cases where all services are performed on the same date. Consultations are services rendered by providers when the opinion or expertise is requested by another provider or appropriate source. If you follow the rule of 3 R's, you should be able to distinguish a consult from the evaluation and management services. The 3 R's are as follows. Your provider receives the request to render an opinion or give advice, and in doing so, they are responding to the request. The response to the request closes the circle, and the decision can be made as to whether this is actually a consult. The patient's medical record must reflect all 3 of these components before a consult code is assigned. The request can be a verbal request, but documentation by both the provider making the request and the provider rendering the opinion must reflect the fact that a request was made. When reporting consultation services for Medicare patients, consultation codes are not to be billed according to CMS policy. If a consultation for a Medicare patient occurs, the service should be reported as follows. Consultations completed in the office or hospital outpatient setting, codes from the office or other outpatient services categories should be reported. Consultations completed in the inpatient setting, these services are reported with codes from the hospital inpatient service category. Consultations completed in a nursing facility category of codes found in CPT should be reported for these consultations. It should be noted that when initial hospital care or initial nursing facility services are provided to Medicare patients, the attending physician needs to report modifier A1, denoting the principal physician of record. This distinguishes the services provided by the attending physician from the consultation services provided. Emergency department services are defined as in CPT as organized hospital-based facility for the provision of unscheduled episodic services to patients who present for immediate medical attention. These codes are used by providers to perform services in the emergency department of a hospital-based facility, which is open 24 hours a day, 7 days a week. Codes in the range 99281 through 99285 are used by ED docs, nurse practitioners, and physician assistants. These codes are not used by other physicians who may be called to the ED to consult or admit a patient. Critical care refers to a patient who requires constant attention by the provider due to situations related to their medical condition and whose illnesses or injuries would put the patient in a high risk should they not get this constant attention. Typically, there's an organ system failure or threat of an organ system failure involved. The patient does not have to be admitted to the intensive care unit, ICU, or a critical care unit of a hospital to be considered as receiving critical care services. If the criteria outlined in CPT at the start of the critical care service category are met, the codes can be billed. Critical care codes 99291 and 99292 are time-based codes. It is essential that the total time billed for critical care codes reflect the time spent exclusively on care of this patient, whether the time is face-to-face or it is spent on the floor providing services for this one patient. The time billed can reflect the time coordinating care, discussing with the family members or other doctors necessary information needed for the treatment, or any other work directly related to the individual patient's care. Related work would include the following: reviewing of test and lab results and radiological images, documenting the critical care service provided by the patient's medical record, time spent obtaining medical history from the patient or other persons involved in the event that the patient's medical condition affected his or her ability to give a history. Remember, the time reported must be directly related to the management of one and only one patient. If the doctor is caring for other patients during downtime while he or she is administering the critical care services to the original patient, the intermittent time cannot be counted. Certain services are considered an integral part of critical care services. CPT lists these services in the note preceding the codes for critical care services. If the service is not included in the list provided, it is allowed as a separately billable service. At times, critically ill pediatric patients, those being defined as 24 months of age or less, are transported to facilities accompanied by a provider. When this occurs, pediatric critical care patient transport should be reported. The guidelines for these two codes are specific. The physician is required to accompany the patient during the inter-facility transport. Face-to-face care is required, and the time associated with the face-to-face care needs to be documented. The coder will note a plus sign attached to code 99467. This indicates that the code is an add-on code and cannot be billed alone. Code 99466 is used for the first 30 to 74 minutes, adding code 99467 for each additional 30 minutes. Two-way communication between the doctor and the EMT or other emergency personnel is reported with code 99288 because emergency care through outside voice communications to the EMT personnel is not considered direct face-to-face communication. Codes 99468 through 99480 are for neonatal and pediatric critical care services provided in an inpatient setting. These codes require the neonate or pediatric patient to be in the hospital and include the same services noted in the guidelines at the beginning of the critical care code range. The guidelines at the beginning of this section of CPT prior to code set 99468 list all the services bundled in the neonatal and pediatric critical care codes. Before assigning a code, in addition to the critical care codes, the coder should pay close attention to the list of bundled services. Code ranges 99304 through 99318 up until 2006 was referred to as Skilled Nursing Facilities, or SNF, Long-Term Care Facilities, LTCF, or Intermediate Care Facilities, ICF codes, but this range is now referred to as Nursing Facility Services. If your provider refers the patient of service as any of the preceding, this is the code range you would use. Convalescent care and rehabilitative care are also provided in these facilities, and these services also fall under this code range. In addition to these sites, patients in a psychiatric residential treatment center would have services coded from this section of CPT as well. A psychiatric residential treatment center provides 24-hour care that includes therapeutic, plan and professionally staffed group living and learning environment. Physician assessment and care plans are required and in most cases affect the payment received by the facility. Domiciliary, rest home, and custodial care services are also referred to as boarding homes. The home or the facility may assist patients with activities of daily living if needed, but no medical supervision is rendered in this type of setting. Patients typically are living in these settings for long periods. This subcategory of CPT is divided into services provided to new and established patients. Approximate time spent with the patient is given for these codes, so documentation of time spent can be used as an element in code selection. Time is not considered a key factor. Travel time is not considered a billable service. Home visit. This category is broken down into new versus established patient visits. The unique thing about home services is that the provider must document why the patient was seen at home in a private residence and is not in the office. This series of codes should not be billed for care planning oversight. Time is allowed as an element when you are choosing a code for services rendered, but travel time is not billable, so only face-to-face time should be documented and included in the code selection. The first subcategory of the prolonged services codes comprises code range 99354 through 99357, prolonged physician service with direct face-to-face patient contact, used when face-to-face time with the patient exceeds the normal service time reported in an inpatient or outpatient evaluation and management code. This code range is further subdivided into inpatient and outpatient settings. Total face-to-face time does not have to be continuous, but the codes are to be used only once per date of service. Time must be clearly documented. These codes are considered add-on codes and can be used only if the time or the basic E&M code billed is exceeded by at least 30 minutes. The next subcategory in this category of codes is prolonged physician service without direct face-to-face patient contact. The guidelines for billing these codes mirror the guidelines for billing prolonged services with direct patient contact, with the exception that there are only two codes in this subcategory, which includes inpatient and outpatient services. The service time does not have to be continuous, but it must exceed the basic service rendered by 30 minutes or more. These codes are used in addition to other services rendered on the same day, but they may be used only once per date of service. They are typically used when there is an extensive extra work regarding a review of records or communicating with the family members, specialists, or other healthcare professionals. Physician standby services is the last code of prolonged services section. It is used when a physician requests that another physician stand by in the event that his services are needed. Standby service does not require direct patient contact. A physician cannot use this code when precepting another physician or if the standby physician performs a service that has a global period attached to it, because the standby service is considered bundled into the surgical package. Typically, this code may be used in regard to a problematic delivery. You must clearly show that the physician spent more than 30 minutes on standby. Care plan oversight is a service that is billed once a month and includes all care rendered to a patient over a 30-day period. These codes are billed by only one physician in a group practice over 30 days to reflect services coordinated or rendered by a physician. Patients in nursing facilities or under the care of a home health agency should not be billed with these codes. Preventive medicine services are provided to a patient who is presenting to a medical office for a well visit or a physical examination. They include a routine checkup, annual gynecological examinations, and other examinations whose focus is promoting health, such as smoking and tobacco use cessation, counseling visits, and alcohol and/or substance abuse structures, screening, and intervention services. Preventive medicine does not typically entail problems, but it can be reported with a problem-oriented evaluation and management code should the occasion arise. If you find it necessary to code 2 levels of service, keep in mind the following. Modifier 25 is necessary to indicate that a separate evaluation and management service was rendered during the same visit as a preventive medicine service, and a separate note is needed to identify the problems encountered along with any additional history, examination, and/or medical decision-making that was deemed necessary to show how this problem was greater than the preventive services rendered. When the coder intends to split the bill or break out a separate E&M service, the insurance carrier should be contacted to see if the separate service will be recognized and if any adjustments to the fee submitted needs to be made. Preventive services codes are assigned whether the patient is new or established, and then by age to the patient. Code ranges 99401 through 99409, counseling and/or risk factor reduction intervention and behavioral change interventions. Individual is used to report counseling and/or risk factor reduction interventions for new and established patients. Preventive medicine services code ranges 99381 through 99387 are for new patients, 99391 through 99397 for established patients. Well visit or a physical examination is used here, age appropriate. Summary: E&M codes are divided by the site of service, new versus established patients, level of service for key components, history, examination, and medical decision-making, and time can be used for code selection that involves counseling and coordination of care that is more than 50% of the time.